Okay, today we're going to talk about trauma systems and go over a few different things. This is again based on a national aspect, but we're going to talk about um, some areas of how we deal with it locally as well. So some of the topics we're going to go over is how the trauma care systems were designed, how we go for the designation, what our criteria is for triage as opposed to which trauma systems we're going to, and kind of our roles in that aspect. So trauma still is the #1 leading killer for persons under 44, although if you've been paying attention, narcotic overdose is actually coming up as #2 right now. So significant increase there as well. But trauma really has been the biggest area, and it's been our most expensive aspect to deal with because of most trauma situations that don't lead to death, lead to major disability, lost income, lost potential to return back to work, and so a lot of rehabilitation and long-term care. So there's been a big push a long time ago with trying to decrease the trauma with safety and other aspects that we'll talk about and how we fix that. So when we talk about trauma in general, there's basically a couple of kinds we're basically talking about, whether it's a penetrating trauma or a blunt trauma. And obviously we have other different aspects of combinations of penetrating, multi-organ, multi-system areas. Our penetrating trauma obviously is anything breaking the skin, and our blunt trauma is basically that which doesn't necessarily break the skin, but it does more damage internally. So these are most trauma that we're dealing with. Only 10% or less are really going to be really our seriously multi-system trauma type stuff. A lot of them are going to be broken arms, broken feet, broken ankles, things like that that are going to be serious to them, but minor in comparison over the total aspect that we're dealing with. So back in 1966 is basically when they led to development of getting the trauma system out there. And that led to the White Paper Act. And I'm not going to really talk about White Paper too much. I'm going to let Gary talk more specific to that. But what happened was the trauma surgeons got together and said, how can we prevent this from happening? What can we do? And actually, if you've remembered my history of EMS, it was actually some trauma docs who were the first ambulances that were out there. And they thought if they could basically fix the problem or stabilize the patient right on scene, they're saving a ton of time. So that's kind of where the guidelines were established. And I say in 1990 is when the Trauma Care System Planning and Development Act came through, and that's when they really started leading to all the systems that come up to where we have now. So now we have a national standard that we really want to go to and kind of follow on. This is where pre-hospital trauma life support, which came out in the 70s, I believe, started coming from, and basically the things we need to do to make kind of a standardization of what we're doing across the country. Now, granted, there are variations locally as well, and what we do in Washington State and Idaho may be different from what we do in Alabama and Mississippi. So there are different variations from this, but in general, we're kind of be set up on a national standard of what we want to do. And so with this system is basically it's integrating, working with the EMS, the pre-hospital providers, with the hospital care and getting that communication to get the best for the patient. By doing this, one, it does all these factors we're talking here. Reducing the costs, basically, if we can get better care and catch them sooner. Their time to surgeries, we're going to talk about, especially in PHTLS, that 60-minute golden hour and your 10-minute platinum time frame that we really want to get through is going to decrease their mortality, decrease their potential for other more debilitating injuries that they could fix if we can get them in a faster time and get them into surgery as quickly as possible. And especially we're going to talk more about bleeding control on that. So how do we decide where we're going? Well, there's different designations for trauma centers. So we got the level 1, level 2, level 3, level 4. There's also a level 5 that's out there, but we're going to talk about the top 4. Level 1, as we know, is only going to be over in Seattle. Level 2, right now we have Sacred Heart. Deaconess was a level 2 at one time. They let it go, and they're looking to try and get that back from what I know. Level 3, you're looking at your Valley Hospital. You're looking at Holy Family. And then our level 4 is going to be everything from like St. Joseph's up in Colville. There is Mount Carmel. So those are going to be there, and then there's also a level 5. We also have now a ER surgery center Deaconess has on the north side of division, and I do not know the designation of that right now. So what's the big difference between a level 1 and a level 2? So level 1 trauma center basically has over 1,200 trauma admissions per year. Where level 2, that's not necessarily a criteria, and we get that at Sacred Heart. And then you need to have a basic good ratio of trauma surgeons, or basically surgeons in general, per patient, so that you've got that capability. It's kind of your span of control. You at a trauma center, level 1, you have immediate surgical capability available. Means you got a trauma surgeon on site 24 hours. Sacred Heart right now at the level 2, they have a 10-minute time frame. They have to live within 10 minutes of the hospital, and that's kind of the same for our cardiologists or neurosurgeons in that. They don't have to be physically at the hospital when they're on call, but they have to be within 10 minutes. So that makes a difference. The other aspect is surgical residents, and especially those doing a trauma fellowship or a trauma residency. Right now with the new the medical school going in Spokane, we are going to have that, and that may be able to bump us up to that level 1 at Sacred Heart. And then research is just another aspect of doing studies, and that there, the hospital I went to, we had to do research programs, and that helped us up with our trauma seminar over at Tacoma General. So trauma center designations. So here's specialty areas that we have, and you do not have to have these to be a level 1 center. Neuro centers, these are basically going to be like our stroke centers as well, which we do have designations at Sacred Heart and Deaconess. Our burn centers are going to be only over in Seattle. Pediatric trauma, we do have that at Sacred Heart. Hyperbaric, we do have a hyperbaric chamber at Deaconess. And then microsurgery, that's with the vascular surgery with using loops, and we have that designation at Sacred Heart. So what's our role in this? Well, big thing for us is doing the triage. Our start triage is basically developing the criteria to start a assessment of the patient and decide where they need to go. So from that, then we figure out where's the appropriate facility. Biggest thing we have to do is anytime we're triaging a trauma patient is if we want to go to a higher level of center, do we meet the criteria to pass by a hospital? So for instance, high trauma going to Sacred Heart, is that truly a level 2 trauma center need, or can we stop at Holy Family if we're coming from the north side? Or if we're coming from the state line, can we stop at Valley? So those are the different things that we're talking about, is knowing of where's the nearest appropriate facility to manage that patient, and do we have to pass a hospital to get to the best care. Mechanism of injury was a good aspect for us determining that triage, but it's not the only factor. And as you'll see as we talk more about backboarding, we talk about things like that, mechanism of injury is not the only factor on that. Let me give you a for instance. So we get an auto versus bicycle. Mechanism of injury, trauma activation, right? Well, not necessarily in some cases. If you go over and assess that patient, no internal injuries, no pain, broken arm, the patient was thrown, wearing a helmet, able to land in a soft area, has no other injuries besides maybe a broken arm, does that go for a full trauma activation? Not necessarily. So does that person need to be C-spine? Absolutely, probably because of the mechanism injuries, and be considering that, but doesn't have to be trauma activation. So that's where I want to say mechanism injury is going to help you to lead to your index of suspicion and going over the body systems, but it is not the only thing that you do. And then kind of as we'll talk about this in PHTLS class, we talk about that golden hour and that platinum 10 minutes I referred to. This is basically to give that patient the best chance of survival, they need to be in the OR within an hour. The quicker you get them there, the better. So we're going to talk about the transport as well. And we're talking about that 10-minute scene time. As you'll see in PHTLS, we want to get that patient packaged, and we're doing a lot of BLS care right off the bat, depending on what we have to do. If we can get that patient packaged, ready to go, and do the ALS care, getting IVs, getting airways, and that established while we're en route, that saves us so much more time. If we're doing an extrication that's taking a little bit longer, then yeah, we can get ALS care done on scene, get IVs established and airways taken care of in the vehicles prior to the removal, or if we're having to have someone entrapped, we can take care of a lot of those ALS procedures prior to we getting the patient released. So things to consider. And air transport, obviously anything we can do to get that patient there faster is what we have to consider. So if we're downtown, obviously we're not going to fly our patient. If we're out in Newport, yeah, we're probably going to be flying our patient. So be considering those type of things of what we need to do. And then basically what's our trauma criteria? So we're going to talk a little bit more about this, and I'll have Dr. Edminister speak to you guys as well about this, because we have a trauma activation, and now in Spokane County we have what's called a partial trauma activation that's been pretty new this year. And so we'll kind of talk about those areas. So we talk about a fall greater than 20 feet for an adult. Well, we can have a fall for less than 20 feet that can still be a major trauma. That's, again, if it's over 20 feet, we would definitely want to be looking at that. But we can have an under 20-foot fall, and it still can be major. So we got to be looking at all aspects. Pedestrian versus bicycle, pedestrian versus auto, sorry. We got to be looking at those aspects of potentially being a serious internal injuries, and so we make sure that we do that. So I always rather you activate a trauma and be on the more cautious side than the unconscious side. So you have to do a thorough evaluation. And we'll talk later about pediatrics versus adult in autoped injuries and how the injuries are sustained and how we react from that. Any motorcycle impact, especially with speed, we definitely have to look about those, because high injury, that's the same as a patient being ejected from a vehicle, which our index of suspicion goes up huge, and we got to be ready for those. And here's another few things we're talking about with severe vehicle impact. Basically, speed is always an area, so we're talking about the velocity. How fast something is going based on its mass is going to have the injury. Anytime we get major intrusion, and again, on some of these cars, the old cars, when they're steel, you get a lot of intrusion, but the interior compartment would be okay. Now with these days, with fiberglass, with lighter metals being on there, you can see a lot more intrusion. You've got to be higher index of suspicion for injuries, especially internal injuries, and we're going to see a lot of these blunt injuries, and we're going to talk about that. Anytime there's a rollover, anytime patient is unrestrained, and the big one here is death of another occupant. One of the things I do like, especially if you're the transporting unit, is getting pictures of the crash site, the vehicles, and that to show to the physicians at the ER, so they can get an idea of basically the type of intrusion, the type of damage that had happened, so they can get a better understanding. The more you can paint that picture, the better, but if you have a picture to show, that's even better there. And then we're talking about extrication times of over 20 minutes. That's going to elevate again because we're talking about those golden hours we have to get through. Other trauma criteria for kids, again, they talk about a 10-foot fall. 3 times height can be a major aspect with kids. So again, over 10 foot, definitely. Under 10 foot can still be a serious area, so you have to be looking for those. I already talked a little bit about bicycle collisions, vehicle collisions, and unrestrained passengers, and we'll talk more about those in the blunt trauma aspect of that and how kids respond versus adults in those type of injuries. Some other areas that we're talking about is our trauma scores, our Glasgow Coma scale scores, and we'll go more over those, as well as blood pressure, respiratory, and rate those. But you can see these findings right here. These are all different things, if they're below these areas, that's going to bump up your trauma criteria as where you're going to send that patient, whether they can go to a level 3, level 2 trauma center, especially in this area. And again, more talking about that. Greater than 2 lung bone fractures. We're going to talk about bleeding in another aspect and how much blood loss you can get from different type of long bones. Flail chest segments, anything that's going to be interrupting with the airway and the respiratory system is going to be huge. Pelvic fractures are going to be the same thing we're going to talk about there as well, with the amount of blood loss that can happen and how to stabilize those areas. Anytime we're dealing with a paralysis, loss of sensation, feeling, motor function, on that is going to bump up our criteria of where we need to go, as well as burns. And burns is going to be an area where a lot of times we're going to have to send a Sacred Heart to stabilize the patient before we can ship them over towards Harborview. And we'll talk more about burn criteria in that, but obviously any burns to the palmar surface of the hands, the groins, and the face, airway involved is going to be our major serious criteria, as well as any penetrating injuries that deal anywhere around the respiratory system or the central nervous system. Huge aspect of immediately jumping that up to more serious. So again, what's our role in this? Well, 1 is getting that patient stabilized. 2, how we're going to transport that patient. And 3, getting them to the hospital as quickly as possible. Again, getting that patient out, getting them stabilized, deciding which hospital you're going to go to, especially if you're bypassing, how you're going to get there by ground or air, and then getting those ALS procedures done. The IV access, airway control should be done in route if you can, or stabilizing, where the BLS area, like bleeding control, and that is going to be done right off the bat with packaging of that patient. Other big aspects that we're a part of, and especially you see in the fire departments going out doing, is injury prevention programs, doing the bicycle safety programs, the bike rodeos we do out in the elementary schools, talking firearm safety, boat safety that's out there. All the safety checks that are done, State Patrol does, Sheriff's does, we do at some of the stations, coming out checking the child restraints, doing the seats checks and making sure it's fit well into the car. And then every time you guys do your PCRs, it's recording and putting in the proper area, because what they do is they take the data from all these calls, from everything that's done, and that's where they get the information to evaluate and make new decisions, make new programs, find out what is working, what's not working, and how we can do that. And that kind of goes right into the QI and why we do this. And that's why your PCR, your patient care report, is so important, and how you document it and getting everything's done, being accurate on there, because all that information is being pulled at certain times to be evaluated for trauma. We do it for stroke. We do it for all aspects, but those are seeing of how well we're performing and what we need to do to improve. So that's kind of what I want to talk about today. We'll talk more about this stuff in class and throughout the whole 6 months of going through, but that gives you a quick update, and I look forward to talking with you here soon.